Hello and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for July 16th, 2025. Thank you for joining us today, and thank you to the current Osteoarthritis Action Alliance sponsors shown here who help support our work, which includes the monthly Lunch and Learn series. So now it is my pleasure to introduce today's speaker, Dr. Nina Cha. Dr. Cha holds a doctorate in physical therapy and is experienced as a clinical specialist in mobility, gait analysis, biomechanics, and neuroscience. As Vice President of Clinical Services at AposHealth, she has successfully advanced clinical operations by collaborating with research and business development teams, demonstrating her ability to integrate multidisciplinary efforts for optimal outcomes. The title of today's presentation is Tech and Innovation in Osteoarthritis Care, a Biomechanical Perspective. Welcome, Dr. Cha.
Thank you. Hello, everyone. Today, we'll take a look at how innovation, specifically through a biomechanical lens, is changing the way we approach osteoarthritis care. OA is a growing burden, and despite available treatments, many patients still fall through the cracks. We'll explore how tech-enabled movement-based solutions can bridge the gap between conservative care and surgery, delivering better outcomes at scale. MSK conditions are among the largest and fastest growing health burdens today. They affect hundreds of millions of people worldwide and place a massive strain on individuals, families, and healthcare systems. In the US alone, MSK conditions cost an estimated $380 billion annually, accounting for nearly 9% of total healthcare spending, more than heart disease or cancer. Low back pain is now the leading cause of years lived with disability globally, and osteoarthritis ranks a close second. OA affects nearly 1 in 6 adults, and that number continues to grow due to aging populations and increasing obesity rates. What makes knee OA particularly challenging is its progressive nature. Once it begins, it tends to worsen over time. As cartilage breaks down and joint mechanics become more compromised, pain stiffens, and mobility issues increases. About 50% of people diagnosed with knee OA will ultimately require a total knee replacement, which is not only invasive and expensive, but also associated with long wait times and variable outcomes. Despite widespread use of treatments like physical therapy, injections, and medications, many people still progress to surgery, highlighting the need for earlier, more proactive, and scalable interventions. With global populations aging and obesity rates continuing to rise, knee OA is on track to reach epidemic proportions. By 2050, an estimated 130 million people worldwide will be living with knee OA, and 40 million of them will experience severe disability that significantly limits daily function and quality of life. This surge in OA prevalence is already placing a heavy burden on healthcare systems, and it's only expected to get worse. Demand for total knee replacements is projected to rise by over 600% by 2030, driven by a growing number of patients who progress beyond conservative care. While current treatments like medications, corticosteroids, and physical therapy can provide temporary relief, they often fall short for long-term management. Many are either not accessible to all patients, not covered adequately, or address only the symptoms rather than halting disease progression. So this raises a critical question. How do we shift from reactive symptom-based care to something more effective, sustainable, and scalable? What's urgently needed are interventions that engage patients earlier in the disease course, can be delivered consistently across diverse settings, improve function and quality of life without heavy reliance on surgery or opioids, and most importantly, reduce overall demand on overstretched healthcare systems. These goals are no longer optional. They are essential if we're going to meet the needs of the OA population in the next decade and beyond. So let's talk about why the current MSK model still falls short. Despite the range of treatments available, pain medications, injections, physical therapy, and even surgery, we remain stuck in a largely reactive model of MSK care. Even the most advanced interventions like robotic surgery or stem cell therapy haven't really meaningfully shifted outcomes at scale. And why? Because most of these solutions don't really address how people move. They focus on relieving symptoms rather than improving function. Most innovations are not personalized. They operate in silos across fragmented systems and ultimately leave patients in a disjointed, inefficient care experience. What's missing is a solution that sits between conservative care and surgery, something non-invasive, movement-focused, and scalable. That's where biomechanical and neuromuscular rehabilitation comes in. And that's where APO stands apart by delivering movement-based therapy in a practical, personalized way that fits into everyday life. And we'll explore that. We'll explore how it works in a more detailed way shortly. But let's go into understanding the pathomechanics of OA first. So when someone has knee OA, the forces going through their joint aren't evenly distributed. So for example, if you take a look at the picture on the left here, it's showing somebody who has medial knee OA. That misalignment increases stress on the medial compartment of the knee. Over time, this leads to more pain, which leads to more breakdown and less stability, and it creates this really vicious cycle. So people often compensate for pain with inefficient gait patterns, and we see this frequently in osteoarthritis. Patients might start limping or shortening their steps to avoid this discomfort. Their cadence will shift, and they spend less time on the painful limb. While this may seem helpful in the short term, it can actually lead to new problems. These compensations disrupt normal movement patterns, it creates asymmetries, and it will often lead to overuse of other joints and muscles. And then over time, this will worsen their pain and reduce function even more. What's important to understand is that the body will adapt to these inefficient patterns more and more. So the question becomes, how do we actually correct this inefficient gait pattern in a meaningful, lasting way? So let's talk about where APOS fits in. Our solution addresses both the biomechanical and neuromuscular drivers of joint pain using technology that's grounded in science and validated in clinical practice. So each APOS device is calibrated and personalized to each patient's pain and gait. It takes their entire kinematic chain into account and not just one joint. The position of the pods shifts the patient's center of pressure during walking, offloading the stress from the damaged part of the knee or the joint, and realigning the way the patient walks. So if you take a look at the picture to the right, we have now shifted the force away from the painful area to a more neutral alignment. This immediately reduces the pain. The convex shape of the pods gives a controlled microinstability that activates key stabilizing muscles around the joint. This muscle activation helps break the pain bracing cycle and fosters long-term motor relearning, a process that continues even when the device isn't being worn. This goes beyond the traditional tools like braces and balance boards and what they can offer by using personalized biomechanical intervention to produce measurable, more long-term improvements. What sets it apart is how it adapts to each patient's movement in real time, helping reinforce better mechanics with lasting impact. APOS sits in a unique position between conservative care and surgical intervention. It's FDA cleared, completely non-invasive, and it's designed to retrain gait over time. Patients wear the device daily while they're doing their normal activities, making it both subtle and scalable, something that's really often missing in today's MSK treatment landscape. But what truly sets it apart is that its ability to reduce not only symptoms, but also healthcare utilization and costs. What we have found in our research was 43% overall reduction in healthcare costs for patients with knee and back pain, 79% reduction in diagnostic imaging claims, 70% decrease in outpatient services, 22% decrease in non-operative treatments, 61% reduction in pain medication use, including 85% drop in opioid prescriptions, 44% decrease in intra-articular injections. These outcomes translate to higher patient satisfaction, lower risks, more convenient and everyday use, all while avoiding costly interventions. And as we discussed earlier, the rising burden of knee OA requires solutions that go beyond managing symptoms. AposHealth does just that. It's helping patients avoid imaging, injections, medications, and surgery by restoring function and promoting long-term change. This is the kind of innovation that bends the cost curve and makes value-based, personalized care a reality. When evaluating treatment effectiveness, effect size gives us a powerful standardized way to compare interventions. AposHealth consistently demonstrates a moderate to high effect size for pain reduction in knee OA, meaning the treatment has a strong, clinically meaningful impact on outcomes. That puts AposHealth in the same league or higher than corticosteroid injections, but with a major difference. Corticosteroids may reduce inflammation temporarily, but they don't fix alignment and movement patterns or pressure redistribution. In fact, high doses are associated with accelerated cartilage degeneration. Compare that to AposHealth, a non-invasive, drug-free, and safe intervention, and the potential to delay or even prevent surgery. And while braces or insoles fall under biomechanical devices, most studies show low effect size or inconclusive evidence because they don't offer the same level of dynamic, personalized gait retraining that AposHealth does. This was a randomized control trial out of Switzerland that evaluated the impact of a biomechanical footwear, which was AposHealth, on knee OA pain. The results were compelling. Patients using the biomechanical device were twice as likely to experience significant pain relief, with over 80% achieving a 50% reduction in WOMAC pain scores compared to just the 42% in the control group. And with AposHealth specifically, we've seen similar or better results not only maintained, but extended over longer durations with additional benefits like improved gait symmetry and function. This randomized control trial evaluated AposHealth therapy following total knee replacement, an area where many patients plateau or fail to regain full function. The results at 1 year were remarkably favorable in the AposHealth group. Patients experienced greater reduction in pain, significantly better function and knee-specific scores, and more than double the improvement in walking distance compared to the control group using a sham device. These improvements weren't just statistically significant, they were clinically meaningful, showing that addressing gait and pressure distribution post-surgery can dramatically accelerate recovery. The authors concluded that biomechanical therapy should be considered as part of standard post-op care, underscoring how gait-based interventions like AposHealth can be integrated across the full MSK treatment continuum. This trial was especially important because it directly compares AposHealth to traditional physical therapy in a challenging patient population, those with chronic low back pain. Not only did AposHealth deliver more than double the pain reduction at 12 months, but it also showed significant improvements in function and quality of life, metrics that are often difficult to meaningfully impact in chronic pain patients. This supports the idea that APOS isn't just an adjunct, it's a viable primary intervention that may outperform standard care, especially when it comes to chronic and persistent biomechanical pain syndromes. For clinicians, this reinforces the value of biomechanical gait retraining, not only for joints like knees, but also for chronic spinal conditions. One of the most compelling findings in this study was that many patients were able to delay or even avoid total knee replacement after just 1 year of using APOS. For individuals already on the path to surgery, this creates a meaningful window of opportunity where one can offer non-invasive treatment that improves quality of life and delays the need for more invasive procedures. So this isn't about just replacing surgery when it's truly needed, but about giving patients another option, one that enhances stability, reduces pain, and helps restore function in a way that's sustainable. By improving movement patterns and addressing biomechanical impairments, APOS can help patients regain confidence in their mobility, stay active, and maintain independence longer. So that's a really powerful outcome, both clinically and personally, for patients trying to manage a progressive disease like osteoarthritis. So to summarize, OA is a growing health challenge, and biomechanics and neuromuscular reeducation plays a critical role in both the onset and management of symptoms. Innovation, especially tech-enabled interventions, is opening new doors for earlier, more personalized and scalable care. So thank you everyone for being here. Would love to hear your thoughts and questions.
Thank you, Dr. Cha, for that presentation. We now have a Q&A time for questions and answers. If you have a question, please feel free to type it into the chat and I will read it aloud. We do have a couple of questions that have come in. I'll lead off with one. From your perspective, what makes biomechanical interventions different from traditional treatments like PT or injections?
I think most traditional treatments focus on reducing pain or inflammation, but they don't really address why that pain is happening in the first place. Biomechanical interventions like APOS are designed to shift the way the person moves and to redistribute pressure in the joint, and then to also retrain the muscles and gait patterns. It's highly personalized and non-invasive, and it's something that the patient does as part of their daily life and not just in the clinic. And it's that combination, that functional, continuous, and gets to the root cause that's focused, and that's what makes it so effective.
Thank you. We did have a request in the chat that asked if you would please show the slide of the APOS again with the biomechanical.
Sure.
Thank you. And then a couple of questions regarding whether these can be used with running as well or can be interchangeable on different shoes.
No, so the device, as you can see, the rails are the device is meant to hold the pods specifically, so it can't be used with any kind of sneakers. We have it essentially looks like sneakers, but the sneakers on the bottom, you'll see the rails, and the rails is what holds the pods. And we have the different levels of convexities. So the A is the flattest, and then it goes all the way up to D's, which is the highest level of convexity, which is the most round. So that's the most challenging convexity that we have.
Great. Thank you for clarifying that. A couple of other questions. How does referral for this start? Like which professional assists with training the patient?
So this is done by physical therapists. So we don't need a referral from a doctor, but we have trained physical therapists that are APOS trained. And once they are trained, then they are the ones who can evaluate a patient and fit patients for APOS.
Okay. And then back to a question about the shoes themselves. Do patients have increased ankle sprains when using these as a side effect? And can these be used on what different types of shoes?
No, so we actually have treated a lot of patients who have recurring ankle sprains for these because this increases proprioceptive input. Patients who've had chronic ankle sprains, they lack proprioceptive input and they have a higher tendency to have increased ankle sprains. So this is really, really great for those type of patients. We can actually calibrate them so that we can calibrate it where we shift the pods laterally and reduce the likelihood of them getting ankle sprains.
That's good to know. And then do you know of any studies that have been comparing this with a knee unloading brace?
We do, yes. We actually do have a study that we've done with an unloading brace. And I want to say it was compared to the unloading brace, it was 13, when you check the adduction moment, we saw an improvement of 13% improvement with APOS of the adduction moment.
That's encouraging.
Yeah. And that was, it was with the unloading brace. And then that was when we were comparing it outside of the device, meaning we always like to check in barefoot, meaning we like to see that the muscles are activating and working. And so it was outside of the device that the adduction moment has changed.
Great. Okay. And then back to a shoe question. You are purchasing the entire shoe, and how many varieties of shoes do you have?
So the device comes, in like all sizes to fit the patient's like shoe size. And the treatment is a year treatment, meaning we are following up with the patient from the moment of the IE all the way up to a year, to make sure that they are, seeing the goals that they want to achieve and that they are, improving and progressing over time. That being said, we don't make as many changes throughout the year because once you make a change, it takes time for the body to adapt. So we find that most patients don't really need changes more than like every 3, 4 months. And that's when we may change out the pod to a higher progressing pod.
Great. And then once you have followed the patient for a year, how long thereafter do you see that the device lasts?
So once they have the device, it's theirs for life. I've been with Apos for 11 years, and I've had patients that have started this and, been with me since the very beginning. And there are patients usually around 6 months, they kind of go on a self-management program because at that point, they are used to doing a normal program with it. Some of them kind of, put it in a closet and they kind of know when they start to feel a little discomfort and they'll put it back on and, they don't need to wear it every day at that point. Some of them have to be a little bit more regular with it. It really depends on the person's body.
That's actually a great segue into a question about compliance, and if you've done any focus groups related to whether or not people will actually wear it once you've gone through the training with them.
Yeah, I mean, we have studies where, um, our knee OA patients, um, we have outcomes where we've been able to push off total knee replacements up to 5 years, and now we're working on a study where we are showing that we can push off total knee replacements up to 6 years because we're following up with those patients.
Great. Do you see that the pods increase the leg length on the affected side?
No, we do. So and the picture only shows one side, but when we we calibrate for both the left and right. We calibrate both sides.
Okay, and that gets to the latest comment that someone asked. If it is only needed on one side, presumably you would want that balance between both
Yeah,
sides.
yeah. So yeah, when we calibrate it, we calibrate both the left and right side. And that's the nice thing about this is that because when something is chronic, it's never just, just the knee anymore, or it's just, it's never just one joint. Most of our patients who come to us, they've kind of, been through everything. And so they come to us with knee and back pain or knee and hip pain. And, we're calibrating multiple joints at the same time. And we can do that with this.
That is interesting, and I think that's true. Uh, can you share any cost information, or do you know if these are covered by insurance?
Yeah, so in New York, Delaware, Pennsylvania, Massachusetts, um, we have insurance coverage. Um, Most of the blues plans cover us in those states. We are working with health insurance companies to get more coverage. Um, in California, we work with an IPA group that has coverage. Um, Outside of that, it is $3,500 for patients. And a lot of patients, if it can save them from having surgery, are willing to pay out of pocket. And we can work with the patients for financial aid and guidance. So, if you have patients that are interested, have them call us and we will work with them.
Great. And then somewhat related, do you have a registry of therapists who are APOS trained, and what their location is?
We do on our website. Right now, most of the therapists we treat our patients in those states through Apos Care. That is directly through us. We have a hybrid model where we go out to the patients ourselves in those states. Um, so because we're able to do a remote hybrid model, we're able to reach patients, um, you know, uh, in those states that's very comfortable for the patients because we go to their work sites, we go to their homes. It's very, very convenient for our patients.
Great. And then you had addressed this a little bit earlier, that these are intended to be useful for the patient for life. Do you see any wear and tear, wear down with use, or is that really variable depending on how
Yeah,
frequent?
as long as they're using it indoors and not outside, they will, they don't really the pods don't really wear down. But again, because we are following up with the patients, the pods, they pop, we can replace the pods.
Okay. Yeah.
Yeah, so if we do have, very few patients that may wear them outside once the PT says it's okay for them, certain number of patients. If they do wear them out, then we can just replace it for them during their normal treatment course. But they're meant to be worn inside, indoors. They're not meant to be worn. They're only meant to be worn like up to an hour a day while they're doing their normal daily activities.
Okay. That makes sense. I am going to pause here. We're nearing the end of our half hour. Certainly welcome any additional questions if anyone has any. I am going to pause just to thank you once again, Dr. Chaw, for anyone who does have to hop off. Um, just to note that next month, we hope you will join us again for our webinar on August 20th at 12 p.m. Associations of bicycling and walking in knee osteoarthritis prevalence and progression, possible implications for osteoarthritis prevention and management, featuring Grace Lowe. I will put that announcement in the chat. If you want to go ahead and register now, you are welcome to. I will also launch a poll for all of you to answer the questions here, if you would, before you hop off. And I do see one other question about the research findings that are all, okay, so the research findings that you shared, were those based on just 1 hour of wear per day?
Um, Most of them are usually the 1 hour is like the max therapeutic dose. A lot of our patients like to wear them. Some of them like to wear them more than the hour, but yeah, most of them are up to an hour of wearing.
Great. Thank you for confirming that. And I don't see any other notes other than someone noted that my voice was too low. I apologize if you were having trouble hearing me. But thank you again, Dr. Cha, and thanks to everyone who attended today's presentation. I hope you enjoy the rest of your day, and we will see you again next week.